Sir.
Yeah, are you able to hear me, everyone?
Yes, sir. Yes, sir.
Okay, okay. So I think all of you are fine after in this long vacation for you in this lockdown period. I think okay, and I hope you are not forgetting anything and you are studying as well as attending classes also. Is it? Okay. Uh, I'm Dr. Venugopal of Orthopaedics Associate Professor, and today I'm going to discuss about this open fractures. Can we start now? Hello.
Yes, sir.
Okay. So, what do you mean by open fractures? What do you mean by open fractures? Any idea? Anyone is having any idea about open fractures? I think very new to the you are very new to this orthopedics. So this is one of the basic topic which you will come across in future. So many cases you need to attend either in casualty or in any other this thing. So which we need to attend on an important and emergency basis, and treatment also must be an emergency basis. Okay. So are you following me?
Yes, sir.
Okay, I need answer. I need voice from many people. Then only I can confirm that you people are following. Okay.
Yes, sir. Okay, sir.
Okay. Then usually the open fracture is nothing but a fracture which is exposed to the exterior environment. That is called open fractures. So the fracture which is exposed to the environment, exposed to outside environment, that is called open fracture. Open fracture is also called as compound fracture. What is the opposite term for the compound fracture? What is the term for the compound fracture opposite term? Normal closed fracture. Closed fracture is nothing but simple fracture. Is it? The fractures are based on their environmental exposure is classified into two types, open and closed. Closed means skin and everything will be intact. So only bone will be broken and everything outside will be seen normal except some swelling, the deformity other than. So and open fracture means along with the deformity, swelling, that this, so the either skin may be broken or soft tissue, other soft tissue may be broken, or directly bone may come outside. Uh, so severe it may be. That is the difference between open and closed fracture. Now understood? I need your voice.
Yes, sir.
Okay. Um, Only a few people are following. It seems I think I need everyone to attend. Don't leave the class. Is it?
Yes, sir.
Yeah, because the so don't keep in this thing mute hmm, and don't do like that. So next, open fractures are most common in case of tibia, which are very common than in any other long bone, because a tibia is a typical example for open fracture, because many of the fractures, open fractures, are tibial fractures. So why? Because it is a subcutaneous bone which is covered only with the skin to one surface, anterior surface. So that's why it is very much prone for open fractures. The rate of tibial diaphysis fractures reported from 2 per 1000 population to 2 per 10,000, and of these approximately one fourth are open tibial fractures. Among all tibial fractures, one fourth of tibial fractures are open fractures. What do you mean by diaphysis? Can you answer? What do you mean by diaphysis? Hmm?
Shaft of the long bone, sir.
Yes, shaft of the long bone. In the mid portion of the shaft of the long bone is called diaphysis, and either ends, complete ends are called epiphysis, and in between the epiphysis and diaphysis, there will be a broad and widened part that is called metaphysis. So you must know these parts. Next, there is a problem. Okay. So, what is the mechanism of injury in case of open fractures? So it may occur in low energy injury, torsional type injury, are more common with high energy injury. Yes, if it is a direct force impact comes directly hitting on your tibia or some this thing while walking or while driving a vehicle, while driving a car. So then it's a high energy injury. If it comes across, then that leads to open fracture. Example: car bumper injury. So next one is the history. The last century, because of no skillful treatment in case of vessels, blood vessels, nerves, if all these are cut, so there is no proper treatment in the last century. So high mortality rate with open TB, open fractures of the long bones were there. So early amputation in order to prevent the death. So in those situations, so the only choice in case of severe open fracture with almost amputated or semi-amputated limb. So the only choice is amputation, complete amputation. Otherwise, patient may go into sepsis and shock and death and so many things. In order to avoid uh, this thing, so we used to do amputations. But now the scenario has been totally changed. No question of amputation. Amputation rate is very low because of improved advancement in neurovascular surgery and all. So the mortality of femur fractures is more than the with open injuries. The mortality of femur fractures is more than the tibial fracture, more than 70%. So now the advances shifted to the focus is mainly the preservation of the life and limb. Before there is a preservation of life, but now the motto is in case of open fractures, it's a preservation of both the life and limb. Why? Preservation of function and prevention also important. When you are preserving a limb, it is better. We need to preserve the function and prevention. Then only it will be useful to the patient. So, however, amputation rates still exceed 50% in the most severe open tibial fractures associated with vascular injury. Yes, because if there is a vessel injury, large blood vessel injury, some cut of femoral artery or brachial artery, in those situations, if a person didn't get immediate treatment, proper treatment, the mortality is still exceeding 50%. So there is a classification for the open fracture. So what is that? So this classification is very important because everyone must know, even from basic orthopedic student also must know. So which allows the comparison of results. So it provides guidelines on prognosis as well as treatment. So it helps in fracture healing, infection rate, amputation rate, which correlate with the degree of soft tissue injury. So based on these things, the fracture is classified. So it is first Gustilo is a the scientists, orthopedic scientists who discovered this, who first upgraded this Gustlow classification again to Anderson. Gustlow Anderson. First initially prepared by Gustlow and later it is modified or upgraded by Anderson. So it is called Gustlow Anderson classification. Another one is the AO classification, and another one is the post classification of open fractures. Among these things, these classifications, Gustlow Anderson classification is most important, which is widely followed. So this is the Gustlow Anderson classification. For only this is, remember, this is for open fractures, not for all fractures. Gustlow Anderson. So it is of three types. Type 1 is a clean wound with less than 1 centimeter in length, because in Gustlow Anderson classification, the parameters which were taken are wound size, as well as contamination of the wound, as well as whether on the, if the bone is exposed, whether later adequate soft tissue coverage is possible or not, as well as periosteal stripping and arterial or blood vessel, other blood vessels injury. Based on these parameters, the open fracture is classified by Gustlow Anderson. So grade 1 is the clean wound less than 1 centimeter, like a pricking wound. So grade 2 is a clean wound which is greater than 1 centimeter length without extensive soft tissue damage, and no flaps, no avulsions, no much soft tissue damage. That is grade 2. Grade 3 is again subdivided into grade 3A, B and C. So grade 3A is a adequate, where adequate soft tissue coverage despite extensive soft tissue damage, flaps, all these things. It's a high energy trauma. So it's high energy traumatic fracture. Even though there is a soft tissue damage extensively, but adequate soft tissue coverage can be done after some treatment. That is grade 3A. In grade 3B, it is same as grade 3A. With the wound is of more than 10 centimeters length, but soft tissue coverage cannot be done after treatment. So while doing treatment, because of there is a periosteal stripping, this is one of the most important factor in case of grade 3B. There is a periosteal stripping as well as massive contamination. Contamination is more, and this one. And grade 3C is the one same as grade 3B, but there is a arterial injury which requires immediate repair. That is a grade 3C. So Gustlow Anderson open fracture classification first published in 1976, later modified in 1984. So the type 1 open fracture, this is an example for type 1 open fracture. If you see here, see there is only a clean puncture wound, small wound, but there is a deformity. There are other signs of fracture. What are the cardinal signs of fracture? Can anyone tell? Can you tell me what are the signs of fracture? Anyone?
Pain, swelling, deformities.
Hmm. Pain is not a sign; it's a symptom. Okay, symptom is the one which patient tells, and sign is the one which you observe as a clinician. Okay, so sign means yes, what you told is correct. Swelling is correct. Then what else?
Restriction of movement, sir.
Yes, restriction of movement. So there are four cardinal signs of movement. Any fracture. So there is a swelling, there is a tenderness, there is a abnormal mobility. The fracture fragments will move abnormally in all directions. Okay, and deformity. So here you can see the deformity. This is the deformity of the wrist. So this is inside out injury and a clean wound, minimal soft tissue damage, and no significant periosteal stripping. So this is an example, typical photograph of a type 1 injury where wound is less than 1 centimeter. Coming to type 2, so there is a moderate soft tissue damage, and so it's a high energy injury. Again, type 1 may be low energy, but type 2 is a high energy. So there is a, if you see the wound open wound, there will be a necrotic muscle and some sort of periosteal stripping will be there. This is the periosteal stripping will be there, and it's a high energy injury and moderate soft tissue damage. And type 3A. Type 3, I told you already, type 3 is based on severely contamination and wound size. Wound size is more 2 to 10 centimeter, up to 10 centimeter. And it's a very, very high energy injury and extensive muscle devitalization and bone coverage with extensive soft tissue. Yes. See, this is a type 3 injury. It is an example for femoral fractures where the femur has come out. So there is a so much contamination. See here, and but still there is no this thing. There is no arterial or neurological injury. Means then you can adequately debride it, clean it, and do proper surgery, and you can make it as it is. So this is a type 3A. See this. Where here the bone coverage with soft tissue is possible. If you keep the bone inside and you can close the wound. Okay, this is the type 3A. So type 3B, see here it's a high energy injury where extensive muscle devitalization and which requires a flap for bone coverage and soft tissue closure. Periasteal stripping is there. See, where is the question here covering? There is no question of covering. There is no skin here. There is no muscle here. Everything gone. So you cannot close it. Hmm? So we need some sort of muscle pedicle graft, flap or something. Okay. So we have to take skin with other muscle tissue from other side and keep here, apply here. Then only you can close. It's very, very highly contaminated injury, and there is a severe loss of periosteum. If you see this in the like a previous femur or tibia, severe periosteum totally will be gone. Here also almost gone periosteum. So see, just blood vessels are exposed out here, but they are not disturbed. So this is the type 3B. Are you able to see the slides properly?
Yes, sir.
Hello? Okay, okay. So this is the type 3C. All you have seen type 3A, B and C photographs, and this is X-ray of the type 3C. In this case also it will be like type 3B. Everything will be gone, skin, muscle, everything will be gone. Along with that, vessel injury will be there, and there is a fracture. So this one usually occurs in case of bomb blast, massive landmine injuries, and war injuries, and also the in case of yes, gunshot injuries. All these things. See, this is an example, either landmine injury or gunshot injury, where you can see some pellets. These are small pellets. Maybe any metal pellet, maybe stones, maybe landmine or something like gunshot, something injury. So in which there is a complete fracture of the tibial bone, as well as in case of this arteriogram, in which there is a blood vessel is also gone, cut here. So this artery, popliteal artery, is gone here. So this one, any grade 3 with major vascular injury which requires repair is called grade 3C injury. Because this classification is very important, that's why I'm stressing so much. Everyone must be able to tell at any time when we ask. Great, just understand. Why we use this classification? Because of grades of soft tissue injury correlates with the infection and fracture healing. Yeah, here because the soft tissue injury is the most important vital parameter in case in this case. Why? Because this the major complication of open fractures is, what is a major complication of open fracture? Can anyone tell you? It's a logically you can think. Anyone tell me?
Vascular
Infection, sir.
Vascular
infection.
injury is rare. Yes, infection. Infection is one of the most common this thing, because there is already we discussed, when there is a open fracture, major problem is the contamination roadside grass, mud, dirt. This everything will be involved in the fracture, as well as so that's the reason. So contamination is very high. So infection rate is the major problem. So that depends on grade of soft tissue injury. In soft tissue injury, injury will be in type 1, type 2, type 3, A, B, and C differently, extensively involved in type 3, C, and B. Then the infection rate is very high. So normally fracture healing also takes longer time. In case of grade 3 1, normally fracture healing takes little less time. So, but in case of grade 3B, it takes very long time. In grade 3C, it takes still long time based on periastial stripping, blood supply loss, everything. Okay, now if you see a physical examination, if you are seeing while sitting in casualty or emergency room, if you get any open fracture case, an intern year, final year, so yes, you can do physical examination. Where there is a neurological and vascular examination of extremity is very important. Whenever any open fracture comes, first you must check the vascularity, because if there is no vascularity means, then immediately you need to think whether we are able to do here or not. Hmm? Refer to higher center or somewhere. So vascularity gone means we need to do investigations as well as treatment, immediate repair if there is a rupture of vessels. So those things. But remember that first life saving is very important. Okay, keep in mind, life saving is very important. Next, think about limb saving. Hmm? Wound should be assessed once in emergency room, then covered with a sterile dressing until treated in the yes. Because once you have to see the wound, and if any blood vessels are there, severe bleeding is going on, then you need to ligate the blood vessel immediately, suture blood vessel, apply some clamp, artery forceps, something. Otherwise, if there is a blood loss, patient will go into hypotension, shock, and death, hypovolemic shock. So first do that immediately, and so you must assess the wound immediately after doing that, and then cover. Then you don't expose the wound outside and cover with a sterile gauze piece. But you need to take a proper photograph. Documentation is very important. Documentation, because you must show in the to the patient as attendant if any question arises, or if you want, later if you want to recollect during your surgery how the wound was before. So you must take a picture of this thing, because nowadays no need of digital cameras because everyone is having a smartphone, so you can have true classification of a wound best done after surgical debridement completed. Yes, so before you need to classify, after seeing the wound, it fits into Gustulus 1, 2, 3 or what, then again you need to debride. After debridement you will come to know, so how many bone pieces are gone in the how many bone pieces are washed out, how many loose fragments gone, how much distance gap is there in the bone, how much bone loss is, everything you will come across, you will properly assess. Then radiographic evaluation is very important. Of course, you need to take AP, lateral, and if necessary, sometime oblique views from the knee to ankle, because dictum is if there is any fracture anywhere between the two joints, then you need to take the X-ray of both the joints. Understand? Understand this sentence? Anyone?
Yes, sir.
What did you understand?
Full length from knee to ankle should be taken for both the joints, sir.
Yes, if there is a fracture in the tibia, you need to take the knee joint as well as this one also. Okay. Total, how many are there in this batch? How many are there in this batch?
134, sir.
Okay. Total, how many are participating now? Who is the number
It's
one?
not
Can you? Huh? Just I want to see who are following, who are not following, who just opened it and left away. Just can you tell one by one numbers? One, two, three, four, like that. Who is number one? Is present or not? Number two,
Sir,
number
present.
three. Sorry,
Present.
number three.
Present, sir.
Okay. Number four. No. Number five. No.
Present,
Number
sir.
six. Number six.
Present, sir.
Number six. Number seven. Eight.
Sir, present.
Nine.
Present, sir.
Okay. Eight present. Nine. 10.
Present, sir.
11.
Present, sir.
12.
Present, sir.
13. 14. 15. 16. 17.
Present, sir.
18.
Present, sir.
19.
Present,
20.
sir.
Okay. 20. 21.
Present, sir.
21. 22. 23. 24. 25.
Sir, present.
26.
Present, sir.
27. 28. 29. 30. 31.
Present, sir.
32. Okay. 31. Who is 31? 32. 32. 33. 34.
Present, sir.
Ah, two are there. 34. So no, don't prompt, huh? Hmm? Because everything is getting recorded. So we'll come to know the voice later. Who are repeating, who are not prompting. Uh, 35, 36, 37, 38,
Present, sir.
okay, 39, 40, 41, 42,
Present, sir.
43, 44,
Present, sir.
okay,
Sir,
44,
43 present.
okay, 44,
Present, sir.
45, 46, 47,
Present, sir.
8, okay, person, 48, 49, 50,
Present, sir.
51, 51, huh?
50 present, sir.
Okay, 51, 52, 53,
Present, sir.
54,
Present, sir.
55, 56,
Present, sir.
58, 59,
Present, sir.
Present,
okay,
sir.
60, 60,
Present, sir.
59. I
Present, sir.
heard some,
Present, sir.
okay, I heard some male
53.
voice. I heard some male voice. Then we will go and we'll go through this class recording. And so, because we will analyze. Uh, so don't prompt. That's the reason. That's why you tell if your number is there, if you are present. That's all. Don't prompt to your friends. Hmm. So don't give proxy attendance. 61, 62, 63,
Present, sir.
64,
Present, sir.
65, 65, 66, 67,
Present, sir.
yeah, 68, 69, 70, 71, 72, 73,
Present, sir.
75,
Present, sir.
Present, sir.
76. Who is 75?
75 present, sir.
Who is the 75 name? 76. Those who are not answering, here will be marked as absent automatically. Because all lectures are getting recorded, so scrutiny will be there. 67, 68, 69, 69, 70, 71, 72, 73, 74,
Present, sir.
75, 76, 77, 78,
Present, sir.
79, 80,
Present, sir.
81,
Present, sir.
82,
Present, sir.
83, 84, 85, 86, 87,
Present, sir.
87, 88, 89, 90, 91, 92,
Present, sir.
92, 93.
Present, sir.
Who is the 93?
Present.
Who is 93? Just name.
Hello.
Hmm? Who is 93? Number 93.
Sadashivam.
Sadashivan. So it's a male, no? Where is the male tone?
Female. Female.
Okay.
Sadashivam.
Okay, okay. Sorry. 94,
Present, sir.
95, 96, 97,
Present, sir.
98,
Present, sir.
97
99,
present.
97. Okay. 97. Who is 97?
Present, sir.
Then why who
Sir,
told?
present,
Who
sir.
is, no, no. Somebody told, no? Boy.
98, sir.
97.
98,
Huh?
sir.
What is the name?
98, sir.
98. What is the name?
Rajesh, sir.
Rajesh.
99.
99
Rajesh.
Rajesh. 98,
98, sir. 98, Rajesh.
99.
Harshvardhan, sir.
So, Ashavardhan should say present. But
Yes,
why?
sir. I told.
So then Ashavardhan is absent now. 99. 98
No,
is present.
sir.
Yeah. 100,
Present, sir.
101,
Present, sir.
102, 103, 104, 105, 106, 107.
Present, sir.
Okay, 108,
Present, sir.
108,
Present, sir.
109.
Present, sir.
Okay, 110,
Present, sir.
100, okay, 11, 111,
Present, sir.
112.
Present, sir.
One, so you're telling for both 111 and 112, huh?
No,
12
sir.
you are,
111 present.
so 112 absent. 113, 113 absent. 115 absent. 116, Absent. 117,
Present, sir.
118, 118, 119,
Present, sir.
119. What is your name?
Gayatri, sir.
Okay. 120,
Present, sir.
121,
Present, sir.
122.
Present, sir.
Because who is 121? 121. So 121 is present or absent now. So you are not sure. So 121 absent. 122
Present, sir.
present. 121 is absent. 123.
Sir, 121 is present, sir. Hello.
Then 122.
Present, sir.
So you are telling proxy for both 121 and 122. So we will
No,
consider
sir.
as
I am 121, sir. Etamat Ilyas.
122.
122 is Muhammad Warisuddin, sir.
So he is absent. So because you are telling both, yes, both. If you say like that, we will treat you also absent.
No, sir.
Hmm?
It's some
There's
audio issue,
quite
sir.
a
It's some
disturbance.
audio issue, sir.
That's why you must be clear and you must be alert while asking your number. Immediately you have to respond. 122,
Present, sir.
123, 124, 125,
Present, sir.
126,
Present, sir.
127,
Present, sir.
128,
Present, sir.
129,
Present, sir.
130. So
Sir,
full length IP
sir,
lateral.
there was no signal from 20 minutes, sir.
Sorry? Yeah?
No signal from 20 minutes, sir. I was listening, but there was signal problems, sir.
For you, huh?
Yes, sir. From you.
No, from my side, I think there is a signal. Everyone is responding, no?
From from you, it is signal problems. It is not coming.
So, so many people are hearing, no?
The there is no proper signal, sir.
But still, how some people they answered.
Sir, I have listened till grade 5 fractures. After that, there was no signals. Grade
Grade
3.
5. I didn't say grade 5. Is there any
Grades
grade
of
5?
fracture.
Grades of fracture.
No,
Okay.
sir. Grade 3. Grade
Okay.
3, sir.
I think only for you there is a problem in the listening till now. So what is your number? Huh?
68, sir.
38.
68,
Okay. 68. Okay. Okay. So for this
sir.
time we will consider for your number because you got some listening problem. So now okay. Attendance finish. Now
Signal
we'll
problem.
come to know how to examine, yes, ankle, knee, and tibia. Also, you need to take tibia and fibula X-ray as well as to rule out the ankle examination. Ankle injuries, you need to take ankle special use like mortise U. And if you are not able to feel the upper distal pulses like the dorsalis pedis and posterior tibial artery in case of lower limb, then you have to go for arteriogram. Nowadays, of course, advanced veneer the color Doppler is there, but now there is no problem. Before there is no color Doppler, so arteriogram, venogram, when is there, they used to do. So now, what are the other associated injuries? Approximately 30% of patients have multiple injuries in open wound injury because of high energy. Fibula in tibia and fibula fractures. Fibula commonly fractures and its degree of combination correlates with the severity of the injury. And proximal or distal tibia fibula joint may be disrupted because if it's very high energy violent injury along with the fracture, proximal and distal joints will be disrupted. So So even because every joint is surrounded by some ligaments and stabilized by ligaments, so ligamentous injury will be there automatically. Soft tissue, that is also very important. Injury means both the bony as well as soft tissue injury. So ligamentous injury around the knee joint is very common. And what do you mean by floating knee? Floating knee is the one where there is a fracture of the distal femur and proximal tibia both in the same limb. So then it is called as a floating knee, which is more common in high energy fractures. Associated injuries. So the neurovascular structures require repeated assessment, and foot fractures are also common. Suppose in case if you consider tibia fracture, you need to check the neurovascular status, and foot fracture also may be there sometimes common. Unknowingly you may miss without taking X-rays later after surgery of tibia and everything. Patient in the ward complains swelling of foot. Then only you will come to know. Oh, yeah, how we miss like that. That's why you need to check everything. So compartment syndrome. Look for compartment syndrome. What do you mean by compartment syndrome? Have you heard this word? Did heard this word or not? Okay, you read compartment syndrome. It is one of the most early acute complication of the fracture. So, it's the increased intra-compartmental pressure within the tight osseofacial compartment. So, which leads to uh, ischemia, change in discoloration, and lack of later blood supply compromise, then later leads to gangrene, necrosis, then finally requires amputation. So it is one of the dreadful complications which should not be ignored. Then, so as we discussed, the most common problem is infection in case of open fracture. The infection may be due to different types of organisms. In case of blunt trauma, there may be a staphylococcus or streptococcus injury, bacterial infection is common. In farm wounds, Clostridia is common. Hmm? And freshwater injuries, open fractures, Pseudomonas and Aeromonas are common. And seawater, Aeromonas and Vibrios are common. And in case of war, high energy, all these things, gram-negative infection is quite common. So you must know, you must have an idea. Every time you will not get culture. Every time patient may not be affordable, and there may not be any provision. So you have to sometime you have to use your brain and start immediate antibiotic also based on type of wound. Usually we give first cephalosporins and aminoglycosides. Use broadly. Are you able to hear? Everyone now.
Yes, sir.
Okay.
Yes, sir.
Then yeah, because the gram cephalosporins we give because gram in cephalosporin first generation will cover gram positive, and the second generation covers both positive and negative, and third generation exclusively merely covers gram negative. So that's why we prefer either gram third generation or second generation. So because second generation if we give it covers both gram positive and gram negative, as well as one extra antibiotic covering exclusively gram negative is also important. So like aminoglycoside, which covers purely gram negative organisms like example gentamicin, amikacin, those things. So we usually prefer like this. That depends on surgeon to surgeon, but must follow the protocol. But as we have to cover both gram negative, gram positive, and anaerobic also. So anaerobic metronidazole, tinidazole we start. Sometimes clindamycin. So whatever it is, but we need to cover gram positive, negative, and anaerobic. So in this, the gram negative is more resistant to many organisms. Patients suffers a long time with the gram negative organisms. So that's why initially we have to put a strong antibiotic to cover the gram negative exclusively. That's why we put gentamicin, amikacin also along with the second generation cephalosporin. Can you name? Can you tell an example for second generation second cephalosporin? Which drug? Cefuroxime. Okay. Aminoglycoside example is gentamicin, amikacin, and all these things. So then local antibiotic therapy, systemic antibiotic therapy, IV can should be given. You need to give tetanus toxoid, TT injection first. Then we need to apply antibiotics locally also. So uh, because which prevents so many infections. But you must know the protocol. First, life saving. Remember always, life saving followed by limb saving. Life saving is the one where you need to check the airway, breathing, circulation. You know all these things. ABC, airway, then breathing, circulation. You must restore. Then limb saving. Limb saving means first you need to check for the distal pulses and go for investigations, and then control the bleeding, and then go for proper x-rays, and then proper debridement. Debridement means you need to remove the all necrosed muscles, necrosed soft tissues, fascia, skin, already dead, this thing, bone pieces, everything you need to remove it. Okay, those things. Later followed by keep the wound open depending on grading of the wound, and all those things. And you need to put some local antibiotics also after debridement in the wound. Mm. Like yes, because if you put along with the IV antibiotics, if you put local antibiotics, the concentration of antibiotic in the wound is very high. So you can manage the dead space, because there is a loss of soft tissue means there will be a dead space. Dead space is one of the potential growth factor for bacteria. So you need to cover the dead space immediately. You can't cover with the other soft tissue by taking graft because of fear of infection. So we have to put some antibiotic beads, which you can cover dead space. Objectives of surgical treatment, mainly you need to prevent the sepsis, you need to achieve union, and you need to restore the function. Our goals of treatment are preserve the life, preserve the limb, or preserve the function also, because without function, preserving limb is of not much use. And also, you need to prevent the infection, and you need to stabilize the fracture and soft tissue coverage. These six things are very, very important, because you need to treat the patient till the last one, soft tissue coverage and wound healing. So soft tissue coverage injury. So after initial evaluation, wound covered with the sterile dressing, and your leg must be splinted. Mm, Support must be given. Then appropriate TT prophylaxis and antibiotics are given, and thorough debridement and irrigation undertaken. See, better if you do within 6 hours any open wound, because the golden period is 6 hours for open wound. Within 6 hours, treatment differs, and from after 6 hours. The patient arrives after 6 hours, because every wound you need to consider as uh, get got infected. So the treatment differs. So you need to check take the photo documentation, and careful planning of incisions, and you need to essentially explore the wound if required to see the other structures. All foreign material, necrotic tissues, muscle, unattached small loose bone fragments, and exposed fatty tissue, fascia, all must be removed, debrided. So after debridement, thorough irrigation with the ringer lactate or normal saline solution. But you should be very liberal in debridement as well as irrigation. Irrigation part is very important, which removes all the debris whatever is there inside. The first debridement is very, very important, which prevents infection. Once infection occurred means without proper debridement, it is a problem for the patient and for you for years together. Yes. And the fasciotomy is performed in case of compartment syndrome. And fasciotomy means you have to release the fascia to release the pressure. So after incision and drainage, new gowns, gloves, drapes, everything, sterile instruments must be used for fracture fixation. So these are the stages of care of open fracture. Initially, you need to assess the wound, airway, breathing, circulation, and emergency room management must be done, and wound dressing and fracture splinting done. Then followed by primary operation. Primary operation is nothing but wound debridement. Already I told you what is wound debridement, and then stabilize the wound. After debridement, it depends. In some large wounds, grade 3B, And grade 3C, you need to put the external fixator for some time. That is also one primary stabilization. So then secondary operation later include, you need to cover the skin and soft tissue reconstruction. So you have to check wherever there is a bone gap deficiency, then skin deficiency, soft tissue. You need to put the grafts and all bone. Then fourth stage is the rehabilitation. Rehabilitation is very very important, because without rehabilitation, patient will get will not walk, will not sit, no movement of the limbs, no movement of the joints. So rehabilitation is very very important. These are the steps of caring. So airway, breathing, circulation, careful neurovascular examination, antibiotic, tetanus. Just I'm summarizing. Local irrigation and sterile compressive dressings, and realign the fracture and splint. Don't culture the wound in emergency department, because you must be very careful. Recheck the pulse, motor, sensation, everything. So preservation of life, limb, wound debridement, and fracture stabilization. So this is an example for incision and dry veneers. So you must use the scrub. Scrub means always you don't do. You must be not be having a powdered iodine or betadine or vocacadine scrub. So sometimes soap and saline also use. If not there means emergency. So that's also used for trauma scrub. Then check the wound in zone site, and then extend the traumatic wound. Then while observing the wound, if the depending on time of the wound, 3 hours, 2 hours, patient comes to you after 2 hours or maybe 6 hours, after 24 hours, your observation is very 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 important, because when you are checking for muscle whether it is viable not viable, already necrose means you need to check for the color, consistency, capacity to move, and observe that properly. Otherwise, it will become we consider as viable. And the contractility, the primary the function of muscle is the contraction. That must be observed properly. So then, if nothing is there, means already that muscle has gone necrose. So there is no point in keeping. You need to remove it, debride it. Otherwise, it leads to infection and later sepsis and everything. Understand? So debridement is very very important. You must know the importance of debridement. So bone ends exposed are debrided and irrigate, and if necessary, serial debridements must be done on second day, third day, and that depends on. So debridement while doing, you need to deliver the irrigation also. Irrigation done by either continuous high pressure or low pressure, with by using bulb syringe, all these things. So see, this is an example for irrigation tube, and here irrigation is going on, and with the gloved finger, sterile gloved finger, is removing the all dead necrotic foreign tissues and all. So like this, you need to thoroughly debride and wash out, and then repeat wash out, then all these things. So, soap solution also can be used, as I told you. Saline can be used for washing. Then antibiotic must be used. So these are the things. Okay. So sometimes you need not cannot close the wound. Only in certain situations only can be closed. Grade 1 and grade 2 wounds. But in case of grade 3 and grade 3B and C, you cannot close the wound. You have to wait for some time. After infection is ruled out, then you have to go for either bone graft, muscle graft, or muscle pedicle graft, or flap. So only thing is you need to protect the limb by proper care. You need to prevent the infection. That is the main motto. So this is an example for stabilization of open fractures of tibia. Later, once after debridement, everything is done, and once you do repeated cultures and wound culture is negative, then if you rule out the infection, then you can go for proper stabilization, like open reduction, internal fixation with the plate, or intramedullary nailing, like locked or non-locked intramedullary nailing. That is different. So this is important. You must know the fracture fixation techniques. This is also one of the basic topic fracture fixation technique at your level. First splint based on external fixation and internal fixation. These are the photographs. This is an example for external fixation, and this is example for internal fixation plating. So in type 1 Gastilo Anderson, it can be treated with the same way as closed fracture because the wound is very less size, less than 1 centimeter. So once you properly debride, irrigate, then you can treat like a closed fracture. Immediately you can fix it. But in grade 2 and 3, usually they are displaced and unstable. So you must restore the length, alignment, rotation, everything. So you must follow proper steps. First debridement, then followed by external fixation, then followed by internal fixation. So, so this is an example for plating in type 1 fracture, Gestler Anderson type 1. So this is the also plating. This is nailing. So intramedullary nailing. So this will be the interlocking intramedullary nail, which we, in type 1 fracture, especially immediately we can do. But remember that once 6 hours is gone, patient comes to you later after 6 hours. Even type 1 wound also you consider as not suitable for internal fixation. You have to treat like a infected wound. That is the most important thing. So okay, complications we will discuss in next class. Understand? All of you are there or
Yes,
not?
sir.
Yes, sir.
So yeah,
Yes,
next
sir.
class. Yes, I will ask one question everyone. So everyone must attend. They should not leave the meeting. So so we will continue next class. Complications and other things. That's all. Okay, thank you.
Thank you, sir.